Hi, Courtney, what's your question? Yes, I believe it's in the week 6, 7 resources. It's chapter 30. Chapter 30, I believe, is upper respiratory. Oh, you're very welcome. All right, I do have a Menti ready for us. So once I can get in here, we'll cover that. Let me get some instructions up here for you. 30, I believe, yeah. Oh, Menti has been really slow. Yeah. Oh, no KWLs today. Good reminder. KWLs is what I do as a learning tool. You can do them on your own. So I suggest, it's always a good tool to use, but that's how I track attendance. On days like today where we have a test, that automatically tracks your attendance. And so I don't do that. Okay, so if you can see the instructions, or if I can make this work, we will start on the Menti. Okay. So I feel like I'm kind of living a case study for you guys. On Monday evening after class, I started having a sore throat. And the next day, I just was like, man, I don't really feel very well. My husband's been not feeling well. And so I decided to take a COVID test last Wednesday or Tuesday, and it was positive. So I got to spend the rest of last week with COVID, which was really fun. The Department of Health recommends isolating for 5 days, which I did. Today is my day number 6. I just said wear a mask around other people, and my symptoms are improving. I am getting better. But as I was preparing the lecture for today, I was like, man, I'm just like living out this like case study for our class. Like as we move through lower respiratory, I had pneumonia, so we could, talk about all of that. And now upper respiratory and COVID issues, like, okay, like we're going to be able to relate and talk about some stuff today. If you're in the Menti, go ahead and give me a little thumbs up or a, what's it called? Reaction. And I do apologize. My brain still does feel a little bit foggy. So if I say something weird, or if you're like, that doesn't make sense, please just like ask me, correct me. I know when my brain is foggy, I might not always be functioning, full throttle. Okay, so we're going to start. Oh man, I didn't have a slide with this. So just to go back really quick, I'm going to talk about upper respiratory. Last week, we talked about lower respiratory, which is pretty much anything trachea and below, right? So the trachea into our bronchioles, out into the lungs, that's lower respiratory. Upper respiratory is everything above the trachea. So it's almost, if you want to just like pop the head off, and anything involving the airway above, like in the head, that's upper respiratory. So if you think about our nose, where we breathe in air, our mouth, our sinuses, our larynx, all of these structures, those are upper airway. Right? So it's really important when you see patients that have, maybe they have infections or disease. Sometimes if it's an upper airway infection, they might call it a URI. Wait, is that right? No, that's not right. Did I say that upper respiratory infection. Thank you guys. So URI, that's a pretty common medical abbreviation for an upper respiratory infection. Sometimes they'll say LRI for lower respiratory infection, but that one's not as common, but you might see that from time to time when you're reading through history and physicals and patients' charts. It's important to know the difference between upper respiratory and lower respiratory, because it's really going to give you a good idea of what we're dealing with. Okay, so we're going to talk about some of the issues with upper respiratory, like patients are going to have. So the first we talk about is epistaxis. What is epistaxis? Yeah, it's a bloody nose. It's usually like, yeah, oh, I even put it here, nosebleed. So it can be from a variety of causes. A lot of times in dry weather, some people, the nose gets dried out. Some people are just more prone to having them. If there's trauma, you get punched in the nose, you're probably going to have a nosebleed. If you have hemophilia, which you guys haven't covered blood disorders yet, but hemophilia is a blood disorder that makes you bleed more easily. What would be something else that would make some people bleed more easily? Cold weather.
Blood thinners.
Yeah, blood thinners, right? That's one thing when we have patients on blood thinners, either warfarin or heparin, Lovenox, we're going to be looking for signs that there may be their blood is too thin, and a nosebleed is something that might be triggering us. It's a cue to say, hey, they might have a little bit too much, too much thin blood. It might be over therapeutic, hypertherapeutic. So what do we do? When you have somebody that has a nosebleed, it's pretty common sense for a lot of people, but you're going to have them sit upright. You're going to put direct continuous pressure. What does that look like? Yeah, exactly. You're going to pinch the nose and you're going to kind of want to get, you can't really see my nose. You don't want to just get like the nostrils. You're not just trying to dam up the blood. You're actually trying to pinch the bridge and you're just pinching in and holding. Because what are you trying to do right then?
Good. Pinch off the blood vessels that the thin ones.
Yeah, like if somebody is bleeding and you hold your hand over it, you're applying pressure so that the blood can clot off, it will stop bleeding. That's what we're doing with the nose. Sometimes we'll put ice. They might even do nasal packing or balloon catheter. Anybody you've seen like the rhino rockets or like what they do in the emergency room? It looks like a nose tampon, essentially. But it goes in and either just goes directly in, or sometimes the balloon, it will inflate inside the nasal passageway just to put direct pressure on the nose itself. Sometimes they'll give a vasoconstrictive agent. They might spray something in the nose that causes vasoconstriction. Because what would that do to the bleeding? Yeah, it's going to slow it down. You've got a blood vessel that's bleeding and all of a sudden you like constrict it down. There's not nearly as much blood flow going through there. So it's really going to help with that. And then electrocautery, and that's just where they use that little cautery tool that like singes the, like burns it closed essentially. So moving on, nasal polyps. That's another issue you might have people have. They're usually benign, meaning they're not cancerous. They're not like this big issue other than they're going to cause obstruction a lot of the time. Usually people with allergies, something about that inflammation can cause those polyps to get bigger. So we're going to try to help control their allergies. They might even have to have surgery to have them removed. And we don't want to do aspirin post-op. Why is that?
Bleeding.
Yeah, right. For cutting them up in here, we don't want them bleeding a whole lot. All right, deviated septum. What is that?
When you're getting on this.
Yes. Anybody had a deviated septum in here?
No.
Yeah. You have to have it surgically fixed
I
too?
had to get a nose job.
Yes, yeah. And was somebody else over here too? You did? Did you get a nose job too?
I did too.
You did too?
In eighth grade.
Yes. Yeah, so most likely we don't have to share experiences if you don't want to, but like usually it's some sort of traumatic event or something that happens. My sister, 3 times within 2 years, had to get her deviated septum fixed. She played volleyball and she just kept getting hit in the face twice. And then another time I don't remember what she was doing, something where somebody, I think they were playing dodgeball and she's got hit in the face. And so poor thing, she was miserable with all of her nose issues. So with a deviated septum, it's just like you think, like, right, it's off to the side. Have you guys learned NG tubes yet?
Mm-hmm.
Right. So when you're going to put an NG tube in somebody, why is it important to know if they have a deviated septum? Yeah. What's a quick way you can see if somebody has a deviated septum, or you can check?
Nose.
What's that?
Look up their nose.
You can look. Somebody else that's not Mickey. What's another way? Yeah, because what might it look like?
One nostril, like.
Yeah, have them take a big through their nose. And usually if the side, the septum is deviated too, a lot of times that nose, like the outer edge, will flap in because it doesn't have good flow and that negative pressure will pop it in. And so it's kind of a good sign, or not a good sign, but it might tell you there is a deviated septum. So usually they'll have blocked sinus drainage. So that side that the septum's deviated towards, they're not gonna be able to drain out like they normally would. That can cause pressure to build up in the sinuses and have headaches. So what do we do for it? So we might do a nasoseptoplasty, and essentially a nose job, right? They're gonna go in, straighten it out, fix it up. We want to look for excess bleeding, look at the dressing. Have you guys talked about mustache dressings
What?
in here?
What?
So mustache dressings, anytime you have somebody that's having like a nasal surgery, you get, essentially, we just do a mask. So you take a mask like this and you roll it up and you put some gauze on top of it and then you put it on them like this. Because somebody that had nasal surgery, do we want to stuff things up in their nose?
No, isn't that to catch the,
It's just to let all that drainage come out, but not like block it up. And so it looks really weird, right? Like, and see what they call the mustache? Sometimes people have specific dressings they look really similar to this, but most hospitals and surgery places are cheap and just will use a mask. And it's good for the patient too, right? You can just throw these away, give them a few, but we don't want to block up that drainage. Why are we looking for excess swallowing? We have a patient who just had nasal surgery and they're swallowing a lot.
this one?
Yeah, that's one symptom of having bleeding after surgery, right? Because if it's up in their nose, it's probably draining back into their throat. And if they're bleeding, we can't really see it necessarily. We might see some if they have like a mustache dressing, we might be able to see a little bit of that bleeding, but that swallowing, that frequent swallowing, that's a telltale sign of some bleeding happening. We want to avoid the activities that increase pressure and avoid aspirin. Why are we, like, what would be activities that increase pressure? Weightlifting. What about if they feel a tickle? Are they going to blow their nose? Right, that's like direct pressure. What about when they tie your shoes? What do you guys normally do? You bend over, right? What does that do to the pressure in your head when you bend over? Yeah, so we've got to help teach them, hey, you might have to bring your foot up to tie your shoes, or you might need to wear some slides, but we really don't want to increase that pressure. Ooh, I have another question for you. All right, we've got some nursing instructions after a septoplasty. So remember septoplasty, so septo, like your septum, and plasty, essentially it's like you're fixing that septum. You can't select all that apply. I keep trying to ask them, and it even says on my end it should, so choose whatever you want. So is it maintain a semi-Fowler position, take stool softeners, use ice, blow, I don't know what that's supposed to say.
Low and suspected low-grade fever for 3 days.
Oh, I think it's supposed to be blow nose gently to remove clots and then expect a low-grade fever. It kind of went over. All right, well, sorry you couldn't select all of them. You guys did a great job. We're gonna have them maintain a semi-Fowler position, right? We don't want them to lay flat necessarily. We want them up a bit. We want them to take stool softeners. Why?
So they're not straining.
Yeah, right, because if they're straining, that's gonna put pressure on their nose. And we want them to use ice. We don't expect a low-grade fever, and we don't want them to blow nose to get rid of those clots. So sinusitis. Word building, right? Our sinuses and then itis. What's itis?
Inflammation.
Yeah, it's an inflammation. It can be bacterial, like an infection. It can also be allergies that people have. So usually you have pain over the affected sinus. So where are your sinuses at?
Here.
Yeah, kind of like all around your face. So usually it's facial pain. If you're usually sinusitis is like all throughout, but sometimes it can be more localized on one side or one area that's really more affected. They might have a fever depending on the extent, and they're probably going to have some nasal discharge. We like to recommend saline irrigations. Have you guys ever seen saline irrigation, neti pots, things like that? Those can be really effective at helping clearing out some of that irritation. Either bacterial or if it's an infection or if it's allergies, right? Either way, you're kind of rinsing out that area, hopefully cleaning out some of that either bacteria or the agents that are causing allergies. Intranasal corticosteroids. So last week we talked about steroids. Remember, I took steroids orally that went systemic through my body. And then I also had the inhaled steroid, like a Pulmicort or Flovent. What is an intranasal steroid?
The sprays.
Yeah, like a spray. So fluticasone or is it
Flonase.
Flonase? Yeah, Flonase. That's a really common one. And so it's just really similar to like the Flovent, like the one that I take for my lungs, but it's a steroid that just goes locally up into your sinuses, right? Because we don't want to give steroids all through your body if we don't need them. We're gonna try to localize it or give it right where the area that's inflamed. We might give some decongestants. Sometimes hot packs can help with the sinusitis. We're going to humidify the air. We're going to give a lot of fluids, right? Because we don't want those secretions in there to get dried out. It's going to get really hard to expel them. They might need surgical drainage over time. That's more extreme cases. The average person with sinusitis is not going to need that. Okay, we're going to play a little game called This or That. So you tell me which one is right. It's going to be one, the other, sometimes both. All right, so if you have symptoms that stuffy nose, headache, and blocked sinus drainage, is that going to be sinusitis or a deviated septum? All right, the unpopular opinion is correct. It's the deviated septum, right? Because you're going to have that stuffy nose because you can't breathe out of that side. And really, the blocked sinus drainage, that's your key. You can't, because remember when the septum is moved off to the side, you're blocking that drainage from coming out. All right, this or that, your interventions are going to be hot packs, saline irrigation, and positioning. Is that for epistaxis or sinusitis? All right, votes in. All right, yes, this is sinusitis. All right, remember, what is epistaxis?
Nosebleed.
That's a nosebleed. Are we going to be irrigating or hot packs to dilate? No, we want to close those blood vessels down. Our interventions are going to be ibuprofen and acetaminophen. Epistaxis or sinusitis? All right, so yes, sinusitis is correct. Why would we not want to give both of these for epistaxis? Yeah, exactly. Ibuprofen is going to increase your risk of bleeding more. So while Tylenol or acetaminophen are good interventions for both, we're not going to give the person with a nosebleed ibuprofen because that might make them bleed even more. All right, what about if our interventions are ice, positioning, and direct pressure? All right, and it's epistaxis, right? We're gonna try to stop that bleeding. For a deviated septum, ice might work a little bit, but if you try to put direct pressure on that one person who essentially kind of broke their nose, that's gonna be really uncomfortable for them. All right, why do we give ice packs for epistaxis? What's the, like, reason? You're right, to promote vasoconstriction, right? We have bleeding happening from the blood vessels in the nose. We want to constrict those blood vessels. When I first looked at this, at first I was like, reduce swelling, but it's not that they have swelling. The swelling isn't the problem. It's the bleeding that's the problem. All right, so obstructive sleep apnea. I was trying to find, our book just really has a small amount of information on this. And so I wanted to talk about a couple of things. Sleep apnea affects a lot of people in the US, and it has some pretty negative side effects, or it can lead to some other medical illnesses. Our book didn't really talk about central sleep apnea, but I want you to know there's two different kinds. Obstructive sleep apnea, I'll show you that in a moment, and that's where usually the structures in your throat and mouth, when you lay down, they relax back and they obstruct your airflow. That's why it's called obstructive sleep apnea. There's another one called central sleep apnea, and that's talking about central, like your brain. So your brain, for some reason, isn't sending signals to breathe like you normally would. So just know, because somebody has sleep apnea, it doesn't always mean it's obstructive sleep apnea. Most likely it will be, okay? But occasionally you might see people that have central sleep apnea. So obstructive sleep apnea, it's apnea or limited breathing while you sleep. Risk factors, the biggest one is obesity. When we're overweight, people are a lot more likely to have obstructive sleep apnea. If you have a high palate, or how your palate, the top of your mouth, how it's formed. Receding mandible, so your jaw. Sometimes if they say, like, if you have a soft jaw where it's kind of like it's pushed back, or like a overbite, or if you smoke, that can also be a risk factor. Let's see, is this the video I put in? I thought this video does a really good job of kind of showing the structures. Okay. This kind of shows what it looks like when they have sleep apnea. This is normal breathing in and out. But then relaxing down, you can see the person trying to breathe, but they're slowly conducted by upper airway. Okay, let me get out of here. So I like how it kind of shows you how how the upper airway kind of like falls back a little bit. And you can, has anybody seen somebody with obstructive sleep apnea? Most of us have. Some of us sleep next to somebody with obstructive sleep apnea. And usually what it looks like is you have somebody who sometimes they snore really loud. Snoring is actually a sign that they might have sleep apnea. And you will see that person, like they showed in the video, where their chest and their belly is kind of moving. They are trying to take a breath, but because it's blocked, it's obstructed, they can't. And then as eventually their body will wake up and they'll go, and then like they're opening up the airways. They might snore a good couple times. And then as they kind of go back to sleep and relax, that airway falls back down and it starts obstructing. They go through cycles of these. So how well do you think these people sleep? They sleep horribly. They usually are fatigued and tired. They talk about people with sleep apnea having a brain fog. They just like, it's hard to think and process. They're essentially sleep deprived. There's a lot of long-term complications. If you have sleep apnea that's not treated, it can also, there's strong correlations with heart disease, like hypertension or strokes, diabetes, other things. There's survey questions we ask most patients, like if you're screening them for sleep apnea, and most of those questions are, hey, do you snore? Or does your loved one say you snore, right? We don't always hear ourselves snore. Do you have, are you tired during the daytime, even after you slept at night? Are you fatigued during, I think I wrote it, and then it also asks too about your BMI, right? Because we know if people are overweight, that makes a difference. Also, people who have a larger neck, we're all built a little bit differently. Patients who have a little bit more weight around their neck are more risk of having sleep apnea. Why is that?
What?
If you have a larger neck, thicker neck.
My son has thick neck.
Right. It's just more weight,
It's just,
right?
yeah, it's a lot of weight on his.
Yeah. So as you lay back, you've got more weight there. that's going to be pushing back and obstructing that. A lot of times these people have a hard time with memory. I have a good friend who was diagnosed with sleep apnea about 5 years ago, and she's a nurse. It took her a long time to go in to even get diagnosed. And she was so mad. She was like, I do not want to wear this thing. What do we have them wear a lot of times?
The scuba mask.
Like a CPAP, right? What does CPAP stand for?
Air pressure.
Yeah, so C is continuous, P is positive air pressure. So a CPAP is when it's just blowing air. And usually they wear a mask. Sometimes it's all over their face like this. Sometimes they have ones that are smaller and they just go around their nose and it blows air. Now you need to have these set up for you by usually a provider. You have a sleep study test or something, and they set it up for you because not everybody needs the same amount of air pressure, right? Somebody who has a more mild case of sleep apnea might need a lower pressure, while somebody who has very severe sleep apnea, they might need more continuous higher pressure. That pressure helps to hold that airway open so you can breathe. Now, my girlfriend was really mad. She was like, I do not want to wear this. This is horrible. I talked to her like the first week. She was like, this is awful. I hate it. I'm never going to be able to sleep like this. Cut to now, several years later, she will not go anywhere without it. If she's staying overnight somewhere, she's doing anything. She is like that little sleep apnea thing or her CPAP. She's like, it's coming with me. Because what she realized after a few weeks of wearing it continuously, she all of a sudden was like, oh my goodness, I'm actually sleeping now. And I wake up and I feel rested and I can think, I'm thinking more clearly. What people don't realize is how terrible their sleep quality is when they have sleep apnea. And then once it's corrected with whatever, so there's also medical devices that they use that they can implant that will help hold the airways open if they're not everybody's a candidate for that, but there's other treatments. But what they realize is they don't realize how hard life was before they had treatment, how really bad it was. And there's so many other things that can happen with our body. So you're going to see patients, I guarantee it, unless you're in pediatrics and even sometimes in peds, they have obstructive sleep apnea. Anybody know what would cause sleep apnea a lot of times for kids?
Tonsillitis.
Tonsils. Yeah.
That's what-
Yeah, exactly. And it can happen in adults too, but most likely we see it in kids where their tonsils get inflamed. Because those tonsils are inflamed and swollen, that causes the obstruction when they sleep and they lay down, those tonsils obstruct the airway. So usually, just like in adults, we'll see them snoring. They might be more irritable and like not as happy during the day. What would be the treatment for a kid with tonsillitis is causing obstructive severity? Yeah, we're gonna take the tonsils out. That's a pretty easy one because it's a pretty normal surgery. But you guys are going to see patients that are going to have risk factors for sleep apnea, and you're going to be doing screenings for them. And they might not even be seeing you for that reason. Maybe you're working at a doctor's office and they're there to get their flu vaccine. But you notice like, wow, they hit all these big check boxes for sleep apnea. I really want you guys to include like health promotion. We really want to try to say, hey, have you ever gotten this check? You know, have you ever really, you should be following it up. My neighbor across the street, Miss Betty, I don't think I've talked to you guys a whole lot. When I taught fundamentals, she was like my living case study. I think I've taken over her role now. But she called me because she couldn't figure out how to set up a sleep study kit. And I was like, a sleep study kit? I don't even know what that is. I thought you had to go, and so a sleep study is how they diagnose sleep apnea. Usually you would go and they hook you up to all these monitors, and you try to sleep at this really uncomfortable, weird place. And then they try to monitor you and see how often you stop breathing. Well, Miss Betty is so funny. She also has diabetes and she got hooked up with a Dexcom, which is like one of those continuous monitors about a year ago. And it's only been in the last couple of months that I don't have to go over every 10 days and help her set up her Dexcom because she cannot figure it out. So she said she's doing a sleep study. I was like, so interesting. Show me what this is. And so she has this box and I open it up and it has like literally there's like 4 instructions and it's pictures. And she was like, no. She goes, why do they want me to hook this up to my Dexcom? I was like, your Dexcom, that's your blood sugar monitor. Let me look. I think she just thinks her cell phone that she has is strictly for her Dexcom. And so anyway, we had to download this app. That's the first thing to do. I said, okay, Betty, what's your password like for your iPhone, like so we can download it? She goes, I don't know. So okay, well, last time we had to download something, your daughter knew your password. Can you call her? So she literally sets her cell phone down and walks over and picks up her home phone to call her daughter. Like, she just does not like using her cell phone at all. But so anyway, going back, we got the app downloaded. And she wore essentially this little watch that connected to the app. It had a little O2 sensor, and then it had a little thing that went up and kind of like a monitor for the chest to kind of measure respirations or movement. And that's how she was able to do her sleep study. How cool is that? Like, that's maybe not appropriate for everybody, but I love that we're in, like, there's new things coming out where people don't have to go sleep somewhere uncomfortable and weird in front of other people to try to get diagnosed with sleep apnea. That's a barrier. And so these things, like this little watch device that checks for sleep apnea, is going to be really nice to diagnose people so we can get them treated.
So is it really thing?
Yeah. I mean, I haven't heard her results yet. I don't know if she has them back, but I was like, wow, that's such a cool thing. Like, we can check people.
Because yeah, they have it on the phone, but you have to pay for it.
Oh, interesting. This one was free through her doctor's office or her insurance. So it might be something to check with your doctor's office. Yeah. So the test, nocturnal polycystim, oh my gosh.
Sleep test.
That word. I'm sorry, I can't say it today.
So
That's
now-
gonna be the sleep study. So the treatment, what are we gonna do for patients who have sleep apnea? Well, we're gonna, first of all, have them avoid sedatives at night, especially, because if they have sedatives, they're gonna be even more relaxed and they're gonna get even more obstructive. We're really gonna encourage them to lose weight, because if they can lose weight, that's really gonna help them to keep that pressure from blocking the airways. Sometimes, you guys have seen the nasal patch, that little thing that kind of like opens, like a little, what's it called? Opens the airways. I used
Yeah,
to
the
see
little,
athletes wear them. Like a nasal strip.
Yeah, it pulls your nostrils.
Yeah, and so sometimes that helps to open the airways in the nose enough that it will help with their sleep apnea. Sometimes they'll do a CPAP, that continuous positive pressure airway. Sometimes patients need surgery, either to help open up some blocked areas. They might kind of reduce some sizing in there, or they have, like I said, those little instruments that they can place that help to hold those open.
Do they do, palate shortening? Like some people do palate.
I believe so, but I think usually it's one thing they try to do everything else first.
What is that, like they cut off a piece from like the mouth? Like,
Essentially, yeah.
like it's backpack?
Yeah.
Oh,
All right, let's think about this cue recognition really quick. I want you guys to put yourself in the mindset of you're at clinicals, you're taking care of your SEP patients, and you've got a patient that's recovering from COVID-19. This morning, they're short of breath and their oxygen saturation is 87% on room air. What do you do? Here we go. Here, go ahead and type in whatever you would do. Couple people, we put them on some oxygen. Oxygen is a popular choice today. What other things would we do? We could even just talk about it. Yeah, sit them upright, right? Positioning is huge. Somebody has shortness of breath. That's going to be your first thing for most people, is get them in a good position. Call 911, maybe depending. Yeah, if your long-term care facility is calling 911 to get help. So some of the things that Davis was saying, recommending, yeah, get the head of the bed up, get them in a good position, get oxygen per facility order. At most places, nursing can start oxygen at 2 liters per nasal cannula. That's a nursing intervention you can just start. You don't have to have a doctor's order. You would want to circle back with the provider, right? If you have to start somebody on oxygen, you want to let the provider know that you don't necessarily want to wait on giving them oxygen for the provider to like get that order to you. You want to prepare for a transfer, and I like it talked about encouragement and support for the family. This is going to be really scary for both the patient and the family. They're going to be concerned, why does this person have to go to a hospital? They're in a long-term care, just trying to give them support and teach them a little bit about what to expect in the hospital. Okay, so we're about halfway through. I just want to do a little check-in. How are you guys doing with talking about upper airway issues? Are we lost? We got it, feeling good? Are we somewhere in the middle? Okay, nobody's lost yet. All right, I like it. How do you guys feel about taking a little break? Yeah, okay. Let's do 15 minutes. So maybe let's come back at 10:35. Excuse me. There we go. All right. So what do we do for these people? Oh, let me click back on here. I think, yeah. So when you guys are taking care of people, or after you graduate, guess what? It doesn't matter what area you work in, there's always going to be people that come to you and they want advice about anything. And so they're going to come to you with a cough or a cold, and you're going to tell them you need to rest and hydrate, because really that is the best thing to do for a cold. You also want to avoid spreading that infection. So what are we going to encourage them to do? Yeah, wash their hands. Maybe stay home from work or keep your kid home from school so you don't spread those germs everywhere. Then we also have what's called influenza. Influenza is different than the cold. It's a specific virus, the influenza virus. One thing I take issue with is that a lot of people, like growing up, I would hear people say, well, I have the stomach flu, right? Where they, like meaning probably that they had diarrhea or they had vomiting. That's not actually influenza. Influenza is when we say about influenza, that's an upper respiratory infection. It's not diarrhea and vomiting. That is something that's different. Okay. So especially when you have test questions, please know when we talk about influenza, that's an upper respiratory infection. It's transmitted by cough and sneezing, just like any other thing. How do we prevent? We want to avoid the infected people. We want to wash our hands. And then there's a vaccination we can get for it. I think, do you guys all have to have your flu vaccine to go to clinicals? So I feel like that's one of the required vaccines. Something that's kind of fun and interesting is that most places in the US, your flu vaccine is going to be different depending on where you live. I believe the Northwest, they isolate for the most 3 common strains that we expect to see with influenza. And we actually pattern our vaccine off of what's in Australia. For some reason, we kind of follow their disease or flu spread pattern. And so it's always kind of a gamble, right? We think like for the next flu year or the next year, we probably are going to see these main viruses, because the flu virus that's affecting us might be a little bit mutated and be a little bit of a different virus that's affecting another part of the US. So they try to isolate for what they think will be our parts or our what's going to be affecting us in this part of the country. Big thing I want you guys to know, because you're probably going to be giving flu vaccines in clinicals if they haven't gotten them already, or you're just going to be talking to people. When you first get a flu vaccine, are you immediately immune to the flu virus? Mm-hmm. No. Are you totally immune to the flu virus anyway? No, right? But it's going to help boost your immunity. How long does it take to boost your immunity to get you where you have some protection from the flu? It's usually about 2 weeks. During that time, what might you be feeling, especially in the first couple of days? Chills, malaise, you might have a low-grade fever. Why are you feeling that way? It's your body reacting, right? Because viruses, vaccinations are stimulating an immune response. They are stimulating your immune system to build up an antibodies or a defense from whatever you're getting vaccinated against. And so because of that response, you're going to have things like maybe some fever, chills, achiness. That's your body responding to the vaccine. It's not that you actually got sick from the virus. A lot of people think, well, God, I just got sick because I took this vaccine, or excuse me. They think they get sick from the vaccine. It's just their body mounting that immune response. Excuse me. Is this more this or that? No. All right. Which patient is more at risk for complications of influenza? Right. So we're going to have a lot of influenza out, but who is going to be the most at risk? Yep. The 78-year-old retiree. Anybody who is older is going to be higher risk. Who else is going to be more at risk? Maybe little ones, very young. Yeah, if they have autoimmune issues, anything that the health is already kind of compromised. So with the flu, you often will have fever and chills. What's myalgia? Where? That kind of generalized
Everywhere.
pain and fatigue. You feel like everything hurts. They also have sore throat and cough, malaise, often headaches. Usually it's a very sudden onset when you have influenza. You go from being pretty healthy to pretty sick, or you really feel it pretty quick. You might have antiviral agents for patients. So flu, I can't remember what the term is, but if you if you have the flu, and how do we know if somebody actually has the flu versus a cold? What do we do? Yeah, you do a test. There's usually little swabs we do, and we test to say, is this the flu or is this a common cold? That's going to help us know what to do. Sometimes people are pretty sick, we give them antivirals that will help them get over the flu a bit quicker. Some other respiratory viruses, I'm not going to go specific on them, but just know you guys are going to encounter a lot. I remember when West Nile was a really big thing, and there was the bird flu and swine flu, and every time it would hit us or hit this area, everybody would freak out. But really, what do we do for all of these upper respiratory infections? Kind of, yeah, we do symptomatic treatment, right? So whatever the person's experiencing, if they're short of breath or if they have low oxygen saturation, we're going to support that. We're going to get them in a good position. We might apply some oxygen. We're going to give them medicine to help support them. And then we're going to try to stop the spread of the infection. So in the next 5-10 years, guys, we're going to see a lot more weird respiratory infections. It just happens. They're going to come along, and we just need to follow general respiratory precautions. So which intervention is appropriate for a sore throat? Somebody has a sore throat, they have an upper respiratory issue. What are we going to encourage them to do? Oh, I like this. We have a couple different answers. So salt water gargle is correct. So what we teach people is to get warm water, stir in about a teaspoon of salt, and you gargle with it. Helps to soothe the throat, pull out any swelling. We don't want them on bed rest because that can increase complications, right? What are some complications when people are put on bed rest? They might develop pneumonia. That'd be my biggest concern. We also have like blood flow issues. They might be more at risk for developing a blood clot if they're not moving around. Hot tea. At first, when I saw this, I was like, why don't we give them hot tea? Well, it's because it's like semantics. They want warm tea, right? We don't want scalding hot tea to burn their throat. Okay, more this or that. So we're talking about the common cold or rhinitis versus influenza. Okay, so slow onset. Is that the common cold or is that influenza? Yeah, it's the common cold. Influenza usually has a pretty abrupt onset where it starts quickly. Will benefit from rest and fluids. Now, this is kind of a tricky one. This is both, right? A lot of times for most respiratory infections, they're going to benefit from rest, fluids, and decreasing the spread. Fevers are more common. Is that the common cold or influenza? Rock stars. Nice job, you guys. It's the flu. What about headaches? Are they more common in the cold or in the flu? All right. So influenza is the correct answer. Headaches are usually more common with influenza. Doesn't mean you can't have them with a cold, but they're just that's typically where we see them more. What about a cough? All right. Both, probably more common in a cold, but you can see a cough with both the cold, common cold and influenza. Sore throat. So common cold, that's generally where we see a sore throat. Sore throat, stuffy nose. Antiviral medications, they're going to be helpful in this. Yeah, influenza, good job. Muscle aches. Where are muscle aches more common? In a common cold or influenza? Yeah, influenza. Nice job. Oh, I already talked about other respiratory issues. We talk about nursing diagnoses as you guys do more clinicals, especially next term. You're going to do a lot of concept maps. And so I want you guys to keep in mind, like, what are some of the nursing diagnoses that we use, right? So respiratory infections, there's going to be impaired comfort, hyperthermia, risk for infections. I must have deleted the other slide because that had another, like, other, I think, more appropriate nursing diagnoses, like alteration in blood gases or impaired it's like there's something that's more appropriate. Anyway, just keep in mind, like when you look at patients, what are going to be their nursing diagnoses? Let's talk a little bit about medication. So kind of like Carly and I were talking about on the break. I really don't like multi-use medications or like NyQuil, right? So I told you guys I started feeling sick Monday evening. And on Tuesday, I came here. I didn't realize I was sick. I thought I just had a sore throat or was tired, whatever. And I came home and was not feeling good. And my husband, who has been texting me saying he's coughing up all this nasty stuff, was like, oh, and he has this bottle on the left on the counter. And I was like, wait, what? This is what you're taking? And he was like, yeah, I just feel terrible. I just needed some Dayquil. Okay, but this is my issue. He thought he was taking medicine to help him with his whole cold, which might be something really good. So this medicine here, if you can tell, it has dextromethorphan. You guys know what dextromethorphan is? It's a cough suppressant. So my husband, who was coughing up all this junk, who was achy and tired and congested, was only taking something to help stop him coughing. When somebody's coughing up stuff, especially during the daytime, do we want to stop them from coughing? No, we really don't. We want to let them cough that up. At nighttime, a cough suppressant might be more appropriate, because we want them to sleep. He thought he was taking maybe something like this, like side by side. They look so similar, right? The average person who doesn't have a medical background is going to think that these medicines are the same thing. But you can see this medicine, actually, I took another picture because I just was so surprised. This one medicine on the right contains all 4 of these medicines on the left. So that's why I just don't like these combination medicines, because people don't know what they're taking and they look so similar to things that might just be one or a variety of things. So what does this have in it? Acetaminophen, right? So for pain, that's a reasonable one. And then it also has dextromethorphan, which is this cold or cough medicine. It also has guaifenesin, which we talked about that. What kind of medicine is guaifenesin? Mucinex. Yeah, it's expectorant, right? Yeah, it's going to help you thin and get those secretions out of your lungs. And then also has phenylephrine, which is an decongestant. Yeah.
Last night, but the check, but nurse thought it'd be funny to have to sniff directly the CO16.
Yeah. Oh, and it smelled like, yeah. Yes, it's usually skunky smelling, right?
Yeah.
Yeah. Was it Tylenol overdose? For Tylenol overdose or?
So if they're giving you too much, in expectorant.
Oh, yeah.
But yeah.
Yeah. So yeah, super interesting. Yeah, so a lot of medicines have different uses, but yeah, that one is also really smelly. Just it sticks with you. But now you'll never forget what it smells like. Um, so really important, we're gonna see patients that come to us for a common cold or the flu, right? Because patients with the cold or the flu might be taking all these medicines. But it's really important that we do some good education and telling them, like my husband went to go fix, I took all of our Sudafed that we had in the house. So this is actually, I think this is our new one. I don't remember. And I was like, listen, I want you to take the box. He goes, I know what it means. I see the box. I'm like, my husband, I love him, bless his heart. He is not medical at all. I still don't know if he understands germ theory. Like, like, I need you to wash your hands. And he's like, I don't know. Anyway, I just was like, I don't trust him to not see something that says Sudafed and then I'm wanting this, but to come back with something that has like all of this in it. So he was really sweet to me. He took the box and matched it up and made sure he got the exact thing that I wanted. But I think this is just a really important visual that we remind our patients when we see them, like, make sure you're reading what you're taking, right? My husband wanted something that was going to help with his aches, with his congestion, and he was really just taking something to stop him from coughing out all that gross stuff. And he's not a dumb man. He's very smart. He's educated. He just is not medically, what's the word? Savvy. There's another word for that we call patients. Anyway. Okay, moving on. So we talked about cough suppressants. Dextromethorphan is kind of like what I was showing you up there. It works in the central nervous system in the brain. So it actually is stopping your cough reflex at the brain. So some patients who maybe have some nervous system disorders, seizures, or they're already pretty sleepy, do we want to give them this medicine? No, it's going to cause increased sedation. So we want to look out for that. We also don't want to give it to children under 4. It's just not safe for them. Other medicine, nasal decongestion, so phenylephrine. So it works by causing vasoconstriction. If you think about when you're congested, everything is kind of swollen. And if you can constrict those blood vessels, you're going to open up those nasal passageways. But we want to give it in caution with patients who have hypertension and other cardiac disorders. Why is that? You're on the right track. So let's think about, it works by causing vasoconstriction. Let's say we have, and I want vasoconstriction in my nose and my sinuses if I'm congested. But what happens if I start getting vasoconstricted in other places in my body? If I have all my blood vessels and I'm starting to get constricted, what happens to the pressure inside those blood vessels? Yeah, it starts to go up, just like a balloon. I like to think about my blood vessels as being like a continuous balloon, like a balloon animal, and if I squeeze it, that pressure, you're gonna see it go up. So be careful with giving our patients with high blood pressure phenylephrine because their blood pressure is probably gonna go up and it might go up to an unsafe area. Briefly, we're gonna talk about cancer of the larynx. Usually it's a primary cancer. So we have different types of cancers that maybe start somewhere else and then metastasize or grow somewhere else. Usually laryngeal cancer is primary, or it starts actually there in the larynx. More common, I feel like I'm a broken record. All the cancers are more common in patients that smoke, which is why it's so important that we give that smoking cessation education. Also more common in people who drink alcohol. Signs and symptoms are very vague, often hoarseness in the throat, change in the voice. They're probably going to do some diagnostic tests to see what it actually is causing that. You can see here, I don't know if you guys ever seen somebody talk with like those little voice boxes that they hold up to their throats or kind of seen them. That's what this is kind of talking about, where this is normal, and then here they open up so they'd be able to breathe through, and then they have to hold up a little voice thing to help them talk. Common risk factors for laryngeal cancer. What do we got? Female, smoker, obesity, alcohol abuse, diet low in fruits and vegetables. It was a select all that apply. Again, it won't let me, but yes, smoker, alcohol abuse, and then diet low in fruits and vegetables. Fruits and vegetables have a lot of antioxidants in it, but you're actually good at helping prevent cancer. So if somebody doesn't eat very many fruits and vegetables, they're going to be at higher risk of having cancer in general. There's some things that can help people talk, and I'm not going to go over the case study. I encourage you to do it, on your own for fun, because it is kind of a good one. And the concept map. All right, that's it. Okay. I don't know what's happening. So, all done. I will let you guys know about test analysis from the test today. I'll update you. Please remember, no class next week because of the holiday. Please tune into the lectures, do the activities, try to engage with the material, because I can't, we're not gonna cover inflammatory, infectious, cardiac disorders in person. It's all gonna be online. If you want to review your test with me before week 9, just let me know. I can go over it with you. And make sure to do your practice test A on the mastery for MedSurg. It's due next Monday. One thing I forgot to say with the mastery test, on the practice test, when it gives you your areas to focus on, I don't see the test that you guys see. It won't let me because of the ATI's test integrity policy. But what I can see afterwards is I can see the sections. So after everybody takes the test, so next Monday, I'll be able to look at that in ATI, and I'll be able to say, hey, you don't have to do remediation on this, and this. So that's why I can't tell you specifically, you won't have to do remediation on this topic, this topic, this topic. It doesn't show up for me until you guys all take the test.
We have to set bars for views.
No, I get a group score.
Oh.
Yeah, it generates, I can look individually, but it also gives me a group report. And then on the group report, and this test will look different than there's a practice B test as well. Like they all look different, but it will tell me specifically different areas. And based on those areas, I can say, oh yeah, we haven't covered this.
So you just send like the guy.
Yep, so after Monday, I'll send out a thing saying, okay, I see your mastery test. We don't have to remediate on, I'll give you a list of areas. All right, good luck on your farm test today. You guys can do this. I think that's it. All right. I'm just stopping the recording.
Yeah.